finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, and no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
Welcome back to the show, everybody. This week we have a wonderful, high-aspiring guest, Dr. Akash Bajaj, who is in sunny California, and I enjoyed so much this interview with him because we got to see the sun while we were here in dismal Oregon. And he is actually triple board certified. He first did his residency in anesthesia or anesthesiology, depending what country you're in. And then mostly because he wanted to be a pain specialist, he did a pain management fellowship or residency. And now he's actually doing functional medicine and is board certified in that. So he tells us how he transitioned across all those specialties and why he got there. And we dive into basically pain management from the acute and chronic perspective of a pain management physician and what they do and how they can help you, to functional medicine and how that's helpful. So stay tuned as we get into that interview that we did with him. Super fun. But I want to share with you our sponsor this week, who, as you know, when you see us in the chamber, we really love our hyperbaric oxygen therapy, and newleafeugene.com is the place to go to find all about New Leaf Hyperbarics and Wellness in Eugene. So if you're in the area where we are, look them up. We use hyperbaric therapy for all our ailments, our aches and pains of aging, our orthopedic injuries, but you can use it for recovering from chronic illnesses, basically respiratory illnesses, any kind of chronic long-term illness such as stroke, traumatic brain injury, MS. They used it for migraine therapy. Athletes looking to enhance your stamina, as well as, I guess it has some uses. I don't know the data on this in children and adults with autism, ADHD. So that's fascinating. They also have red light therapy available, which red light therapy is
massage therapy.
Yeah, and massage therapy. And you can combine modalities. We use red light therapy when we are in the hyperbaric chamber. You don't have to be worried about being claustrophobic. Tim kind of doesn't like small spaces. He does fine. They're almost like tents, really. So you can actually fit quite a few people in the big chamber.
The last time we went, we had a 2-hour session, and I actually had a business meeting whilst I was in the chamber.
Yeah. He's taken naps, read books, had business meetings.
Yes.
So check out newleafeugene.com and find out if hyperbaric therapy is right for you, or red light therapy. I would love to do a show on red light therapy, and I've been hunting that one down. So thank you, Matt McCarl at New Leaf, for sponsoring the show.
All right, here we go with Dr. Akash Bajaj.
All right, everybody, welcome back to another episode. And today's guest, as I mentioned earlier, is someone who I already feel like I'm just not worthy, because he is triple board certified. Let's just start with there, in anesthesia, pain management, and then functional medicine. So welcome to the show, Dr. I'm just going to say Dr. Akash and call it good, if that's okay.
Okay.
So thanks for being here. So why don't you start and let everybody know, like, how you got, what field of medicine you're drawn to, and then how your career evolved from anesthesia, I guess, and down the line.
Yeah, no, sure. Well, first of all, thanks for having me, guys. So I originally started in anesthesiology, and from anesthesia, I went into, well, let me back up and kind of give you the whole story. So after my undergraduate training, I went to New York City for medical school. And while in New York City, completing my MD, I was actually a first responder for 9/11. And so after that experience, I really kind of saw pain in general being very undertreated, and just kind of ignored, because so many physicians at the time didn't really understand how to properly treat it. So for that reason, I decided to change my career path into pain management. And at the time, the only way to really get into pain management was to pursue anesthesiology.
Ah,
So I
so
ended up,
so from the get-go, that's
go
what you
ahead.
wanted to do was pain
Yeah,
management, basically.
yeah, totally. So I did anesthesia as my original residency. And from anesthesia at UCLA, I then went into pain management at UC San Francisco. And after that, then I started, I took a job initially, which was great, but I realized I kind of had my own way of wanting to do things. So I started a private practice in Los Angeles.
Uh, so,
So that private practice was what we would consider traditional pain management. So
Yeah, so that was about maybe 15 or 16 years ago. And that was traditional pain management, which at the time consisted of, a few tools in our tool chest, things like opioid prescribing, medication management, and just a handful of traditional cortisone-based injections. So coming out, starting my practice, that's really the only tools that I had to work with.
is it pretty much standard? So when I'm thinking of the patient, so we've been out of primary care for a while doing urgent care, at least I was since 2010. But when we were referring
Hmm.
patients to pain management, you're right. It was pretty much the chronic difficult patients that we didn't want to do. Oftentimes the injections with steroids, say the blocks and so forth, were done through anesthesia department, but sometimes pain management. I don't
Yeah.
remember anybody going there for any cortisone. Like usually orthopedics or somebody would take care of that. It was pretty much opioid or referring to PT, kind of just
yeah, I
being the
mean
quarterback for managing people's.
some guys would put in nerve stimulators
Yeah.
or morphine pumps, which just sounds like such a great idea. You know, if
That
you
was kind of the go-to thing to do back then. I mean, spinal cord stimulators are still great, and to be honest with you, the medical technology in those has improved so much, where that's still a great modality. Now, the intrathecal pain pumps, I used to do those, but I started to see diminishing results, just like uh, oral opioid management, right? The same problem exists, which is ultimately you keep escalating a dose of an opioid medication to obtain the same result, right? Ultimately, what we call tachyphylaxis. But at some point, your risks outweigh any sort of benefit. So that's when you started to see these patients during the opioid epidemic, where they're having these fatalities and all these kind of respiratory suppression issues, et cetera, et cetera. But they just needed more and more medications to hit that same level of benefit. So it was really tragic and a really kind of mismanaged way of dealing with pain. But it kind of goes back to what I was saying earlier, which is we didn't really know what else to do. And not only that, but we were literally taught as medical residents and medical students that pain is the sixth vital sign. And doctor, if you don't treat it, you could be penalized or you could get in trouble.
yeah, and
Right.
people forget that because I really held the medical profession responsible for a lot of the opioid stuff because we knew better. And and we just ignored it. It's just weird. There's like this weird human bias to new information. And the story of how in 1980 there was a letter to the New England Journal of Medicine, and it was a paragraph long, talking about treating 500 patients, and that if they had legitimate pain, they would never become addicts. And it's like we were like, we have this new knowledge about opioids, even though people had been using opioids since the Sumerians 3,000, 5,000 years ago, and it was
Sure.
never good. They're always in pipes. And
Hmm.
you sit there and you go, that one letter got recited, I forget,
Hmm.
like 11,000 times in journals, and it just became holy dogma and killed so many people. Like it was so terrible. And there was virtually nobody screaming from the rooftop saying, we're doing this wrong. We're doing this wrong, because you would get slapped if you weren't prescribing pain medicine. It was just seems so crazy now.
That's right. That's right. And not only would you get slapped, but it was kind of the sheep mentality, right? Where if this is the dogma that's being taught and all of your colleagues are doing this and you're not, let's say you're in a larger group, you're not going to be penalized by the group, which means your income may be adversely affected as well. So all the practical considerations as well as the kind of false physiological justifications, we'll call it, right? It was kind of the perfect storm to create that situation.
So before we even segue into what you're doing now and how you got into the more functional, regenerative, anti-aging medicine field of things, let's sort of stick with pain management, acute, chronic, for a bit, and what works, what doesn't. Because I know we have a lot of listeners, and our listeners are probably majority is non-physician, non-medical based, who might have known somebody, gone to pain management themselves, or at least know somebody. People know what it is now. So what's sort of working currently up to date that you know of? I know you're not maybe directly in the field, but other than opioids, where are we at with doing things like steroids as far as using those? I know they're kind of falling out of vogue. I know even for orthopedic issues, they don't like to use them as much as they used to. What's going on in that field there?
Yeah, so I mean, in addition to medication management with the field of pain management, there was the other side of that coin, and the other side of that coin was really interventional based therapies, right? And still is to this day. And those therapies include things like cortisone or steroid based injections at different parts of the spine, certain joints, or what have you. So, for example, we've all heard the term epidural, right? So, the term epidural really just refers to an anatomical location in our bodies. Now, once you enter that space, you can really inject anything. Like, for example, childbirth, a labor epidural, you're injecting a local anesthetic to just anesthetize or numb things up. But with pain, you can have sciatica, right? And I can talk a little bit about that in a moment. But if you're dealing with something acutely painful like sciatica, injecting a steroid directly near that affected nerve root can mitigate those symptoms. So this started kind of the basis of interventional pain management, which actually originated with the anesthesiologists, because that's something that we would do in the pre-op or post-op area, literally in just the hospitals without any sort of fluoroscopic imaging or guidance or what have you. But that's now matured where really the standard of care for any sort of injection-based therapy is to use fluoroscopy, which is basically a live x-ray to specifically target the area. And I think it really all kind of started with sciatica, to be honest with you.
Is that right? That's interesting, because I always think of things like spinal stenosis, diagnostic testing for most of, our patients early on. It would be like spinal stenosis stuff. They go in there for injections more than sciatica. So now acute sciatica, you're not going to be, obviously, at least not around here. No one's getting in for that. But chronic stuff that's not resolving, I'm assuming. Have you ever done any for acute sciatica? Can people get in that quick?
Well, yeah, honestly, yeah. I mean, we're very aggressive, I guess, with that. Like, we like to get patients in within 24 to 48 hours.
Wow.
And honestly, the reason for that is because I have sciatica. I have a 9 millimeter disc at my L4-5. So I've been through the process as a patient as well. And having received, like, knowing what I know with the risk benefit profile, I had a colleague give me 3 epidurals within 1 week. Super, super aggressive, but it worked. I avoided surgery. I was supposed to have surgery, and that was like 18 years ago. And so far, so good, right? But just taking a step back in respect to the term sciatica, people hear this term all the time, but what does it really mean? So the term sciatica really comes from the sciatic nerve. And the sciatic nerve, it comes from 3 branches of the spine, L3, L4, and L5. So anything that causes any sort of irritation of that nerve at those levels can cause sciatica. So to your point earlier, that could be stenosis, which is basically a narrowing of the spinal canal, but that stenosis can occur at the nerve or around the spinal cord itself. It could be a disc that's bulged out or protruded out from a traumatic episode like a car accident or a fall or something like that, also potentially genetic, or it could be arthritis and just degeneration, where a disc, which should look like a jelly donut, now looks like a flattened pancake. All of that can cause a narrowing or a stenotic appearance, causing sciatica. So sciatica is kind of an umbrella term. It's very kind of loosely used, but the real question is what's causing it, and that's where we would really focus the treatment.
Right. Definitely, that's what we'd try to tell patients too, because everything. It's like, oh, I have sciatica, so they all assume they got a bulging disc, etc.
That's right.
How often do you see muscle spasm or piriformis syndrome trigger that? Just out of curiosity,
Super.
Yeah.
Yeah, really good question. Super common. So 67% of the time, the sciatic nerve runs through the piriformis,
Hmm.
and 30% of the time, it runs through a parallel muscle called the obturator internus. So these are the patients that you may see that participate in like asymmetrical sports, like snowboarding, skiing, surfing, kiteboarding, things of that nature, where their pelvis is moving in an asymmetrical fashion. It can cause the piriformis muscle to reflexively spasm and tighten up to protect the pelvis and kind of minimize that movement. And if that happens and that sciatic nerve is running through that muscle, boom, you squeeze the sciatic nerve, causing sciatica with potentially a normal MRI.
Interesting. I never even would
Yeah.
think of like a sport like that where you're right, using one side more than the other. Makes sense. I mean, for anything else that you're doing, things go out of whack and one side, your low back hurts, you're out of kilter.
Right.
So how effective is doing the epidurals for that? Do you do epidurals for like a piriformis syndrome, or I mean, I'm thinking you just do PT and stretches and
Yeah, you always want to be as conservative as possible,
right,
right? In,
right.
ge- in,
Yeah,
in general, with everything we're talking about, PT and potentially chiropractic care,
right.
stretches, acupuncture, they all play a very vital role. But at the epidural space doesn't actually extend down to where that muscle is, but you can do just a cortisone-based or steroid-based muscular injection directly into the piriformis.
Yeah.
Now, what's good about the piriformis is, as pain management specialists, we know the anatomical landmarks, so we can see them on a fluoroscopy, which is basically the femur with the leg bone, and then the sacrum, which is the tailbone. So that's the kind of pathway of the piriformis muscle. And once you see that pathway, you can literally light it up under an X-ray with a bit of dye, and then inject it. And patients notice pretty quick relief.
So do you use ultrasound ever for this, or
Totally. Yeah. With certain injections, you can absolutely use ultrasound.
because
Anything muscular based. Yeah.
like I've told
Go ahead.
because I've told patients now, I said, like tendon injections and all that kind of stuff. The standard of care, somebody's got to image that now. I mean, doing that stuff blind, those days are gone.
Totally. Totally.
I'll do hips. Shoulders and knees are fairly easy. They're big joints. I've done hundreds of them. That's not a big deal. But they're
Sure.
doing hips under ultrasound, which is just fascinating. I mean, that used to be tons of fluoro, and just almost nobody
Right.
would ever attempt it. And
I
Totally.
now they got the
I had
sports
mine
guys doing
done.
them. Yeah, I
No,
mean, it's just
I had a hip replacement. Well, two now. Just one of them 7 weeks ago. But I remember my first
Oh,
one was really
wow.
bad, and he said, "Till you get in, let's just do." He did, yeah, in office, just under ultrasound. I'm like, this is crazy. I don't know if I trust this needle
That's
going
the,
so close to my groin. But yeah,
you're so thin though.
anyway,
It's not like it's not like
that's
some
awesome.
folks that require more of a harpooning than
Right. Right.
so.
Body habitus definitely plays into it. There's no
Boy,
question about
yeah,
that.
it can be a challenge for sure. So tell us about so you're having tremendous amounts of fun writing prescriptions for opioids
I'm
for
thinking I'd be.
the good
No, wait,
people of
wait.
Los
But
Angeles.
I'm thinking you'd be having tons of fun. See, that would be the fun part is the procedures, injecting people with
Oh,
either
yeah. It's
anesthesia or steroids, but that there's a limit, right? You're still not going to inject somebody's spine more than how many times with steroids? Same as any other
yeah.
joint.
Yeah, pretty much, right? And that's
Yeah.
exactly kind of what happened in my experience. Is I started with the traditional kind of, tools that we had, but then I started to realize these kind of chronic opioid pain patients, they're not getting any better, like I stated, and they're just kind of, you know, circling the drain, I guess. They're not really doing anything, and they're becoming less and less productive. Their quality of life is decreasing. So I actually stopped doing that completely and moved strictly to the interventions. Things like epidurals, like we talked about, facet injections, which is basically an arthritic joint in the low back. They're symmetrical joints, one on the right and one on the left, and they, like any other joint in the body, can become arthritic. And when that happens, they get inflamed, they get enlarged, and that can cause just kind of a chronic aching low back pain. This is typically what you hear about when patients get up and their back hurts, but they start moving around and they feel better. That's facet pain. So that's another type of injection therapy that we offered. But then I started to realize, okay, when when somebody comes in and they get three epidurals or three facet joint injections and they're doing great, but then that wears off because cortisone always wears off. Now what? Now we have this kind of awkward meeting where I'm staring at them and they're staring at me. And I'm like, maybe try some physical therapy. I don't know. Come back in 6 months when I can do another injection, right? And that's just not really an ideal treatment plan. So then I kind of transitioned over to more of the regenerative therapies, things like PRP and stem cells.
So before we jump into that, can you explain to our non-medical people why you can only do so many steroid injections or the time period in between? Is it always 6 months? Can you then recircle that? I've heard some things, actually a fellow, I won't say, but a colleague had too many steroid injections even in the hip. So it started to destroy the bone, so that when they went to do a hip replacement, it was a mess. But there's a limit. So can you explain sort of what the time period is and why that happens?
Yeah, no, totally. So steroids, if you take a step back and just look at the entire body, right? Because sometimes this is what we forget to do is understand that we're injecting into a human body, and anything we're injecting is going to have systemic or total body effects. So steroid is actually the precursor or kind of the original, the OG molecule to create all sorts of hormones that fall underneath it. Things like testosterone, things like estrogen, things like pregnenolone, progesterone, just all these other chemicals, right? So if you have exogenous or steroid coming in outside of the body, you're not telling your body, hey, we have enough steroid, we're good to go. Let's go ahead and turn off our factories to make it internal or endogenous steroid. That's that negative feedback loop. So once you turn that off, now your body's not making steroid. So now you can have all sorts of negative effects, things like skin changes, mood changes, sleep disturbances, decrease in bone density like osteonecrosis, which is what you alluded to earlier, even osteopenia or osteoporosis. Then you could have the opposite thing happen as well, which is if you're getting just pumped with too much steroid all the time, now your body has too much steroid. And this is when you begin to see things like potentially Cushing syndrome or things like that, where you just have overexposure to steroids or underexposure to steroids, just all sorts of different maladies that can occur. These are the patients you may see. They tend to be older, where their skin, if you literally just kind of put a Band-Aid on their skin and take it off, they start to bleed. That super frail skin, that's all related to kind of mismanaged hormone therapy.
Yeah, absolutely.
Yeah, they come in with a big skin tear and it's like tissue paper, and they're like, awful. Do I need stitches? And I'm
totally.
I'm like, no, you need new skin.
That's horrible when that happens. I hate putting, I hate wrapping those up.
Oh man,
what a mess.
Trying to unpeel that, you know.
I just get the
right.
My grandmother wasn't on steroids, but she had that same kind of skin. You know, you'd look at it and it would bruise and rip and tear, and it's just nasty. But so now you're at this impasse, basically, where you're kind of looking at your patient, going, "Well, we've exhausted these options, and you're not living your best life on maximum narcotics anymore. You kind of peaked out, and gee, imagine that life isn't better." So now you're looking. Was it really the fact that you wanted to do more for your patients in ways you could help with this pain? Or how much of the fact, or is it also, it's tough, I think, as a physician who is dealing with chronic pain. I mean, people understand that it's when people are in pain or, hurting, and they're always the happiest. It's not there because they're having a happy day and they come to get their, their plastic surgery and everybody's happy, or it's a positive outcome at their new knee or their new hip. They leave feeling great. Now, these are tough patients sometimes, for sure. It's like even migraine patients. So that can wear on you and your career. So was it a bit of both of that? Or was it more just looking for other avenues for your patients?
A little bit of all of that, I mean, there's nothing like being a doctor where you try to, you're creating a situation where you want to help people and you come to this impasse and you literally have nothing to offer that person. That is not a great place to be as a physician, right? As I'm sure you guys can understand. Yeah. So that kind of sparked the interest to start looking at other possible options for these patients.
So tell us how you, what you did then. So you went and got certified in functional medicine, board certified in functional medicine, pretty much said, hey, this looks like an avenue where there's other options.
Yeah, what I started doing actually before that is I started doing PRP. which is platelet-rich plasma. And the reason that I had started doing that over 10 years ago is I'd begun to hear a lot of these professional NBA players were going overseas to get these procedures done, and they were coming back and they were, winning the playoffs, winning the championships. And this was amazing. I first heard about it with Kobe Bryant doing it, so I started looking into it. And at the time, what they had available overseas, we did not have in the States. However, that eventually changed, and obviously more and more was available here in the States. So at that point, I started implementing these therapies into my practice. Like PRP, for example, is very common, I would say, nowadays, but back then it was not. And we just noticed a few things. One, patients are not getting exposed to steroids, which is great. So they don't have any of these untoward side effects with hormone imbalances and everything else we talked about. Two, there's really no limit to how much of these injections they can get. So if they're a professional athlete, or if they're a weekend warrior, or if they just want to play with their grandkids, you can custom tailor their treatment plan to what they need. And three, it's all natural, right? So there's no preservatives. Everything is done in one sitting. There's no contamination risk, really, as long as you're completely sterile during the process. And there's no potential risk of any sort of allergic reaction to anything within the compound because it's just purified components of their own blood. So PRP stands for platelet-rich plasma. And basically what that is, it's a small blood draw, about 30 to 40 cc's, which is not much at all. And we take that and put that in a special centrifuge to spin it, separating the platelets from everything else. And then we just take those platelets, and those are typically re-injected into the affected area. Now, that could be the epidural space, that could be a bad knee, a bad hip, a bad elbow, or whatever the case may be. And the theory behind PRP, as far as how it works, is really twofold. One is the platelet-rich plasma releases a bunch of growth factors, millions of growth factors, wherever you put it. So those growth factors, in essence, are acting like reinforcements being dropped into the battlefield. So they kind of help your body heal whatever it's trying to heal in the first place. That's why you're inflamed. And the second thing they do is your body now sees all of a sudden there's a large collection of platelets in an area where there once wasn't. So it almost tricks your immune system into thinking there's a new injury. And when your body thinks there's a new injury, it sends more immune system mediators to that area. It kind of activates your immune system. This is why sometimes after a PRP injection, a patient may feel kind of sick or like they're having a fever or just malaise or just kind of down and out for a day or two. This is the reason why, because their immune system is actually getting activated.
Fascinating.
So who
totally makes
like
sense.
who came up with it? Like
Yeah,
this
I was
is
just wondering
this
the same
always
thing.
reminds me of the and you would know about this being trained in anesthesiology, about the slow acetylators of succinylcholine.
Oh, jeez.
And how that the test to test for your acetylation rate of succinylcholine was based on salmon semen.
I'm glad I didn't have that test.
The salmon semen, whatever it is. And I'm like, how did they come up with that? And I'm thinking, can you imagine going to a cocktail party and it's like, what do you do? I collect salmon semen for anesthesia groups. What do you do?
I top that answer, right?
Yeah. How do you collect it? Well, I'd rather not go into the details.
Right.
Yeah. No, I mean, it's wild. So this idea that,
Oh
we've been treating everything with anti-inflammatories, cortisone being the king of anti-inflammatories, so to speak, non-steroidal anti-inflammatories, everything's anti-inflammatory. And now we're trying to inflame the heck out of it with PRP. Like, where did this come from? Like, was it some mad scientist?
It was a back alley fight, and the guy felt way better after they took a couple rounds.
Or was it somebody just going, if the body makes inflammation, maybe it's actually good. Just like we make fevers, maybe they actually do something that's helpful. I don't know, right?
Well, that's the case right there, right? We've always known inflammation is not necessarily a bad thing, but chronic inflammation is a bad thing, right? Because your body is trying to heal something. That's why you get inflamed. But most of the time, the practical considerations, let's say a knee, for example, if your body's trying to heal a knee, you're still walking around, you're still weight bearing on that knee. So you're never getting a chance, your body's never getting a chance to completely heal that knee. So you become chronically inflamed, right? And you cross that kind of line from acute to chronic at about 3 to 6 months, depending on what you read, then you're chronically inflamed. And then your chances of potential benefit really go down. Your prognosis really decreases at that point. So inflammation we've always known is a good thing, just like fevers are a good thing. We know your body's trying to heal something. This is just a matter of accelerating that process, increasing the magnitude of what your body's trying to do so it can actually complete the process. But to take a step back, there was an interesting intermediary between PRP and cortisone, which some doctors still use, called prolotherapy. Have you guys ever heard of that?
Yeah.
I have.
Where you stab the living
Yes.
crap out of whatever
Yes.
that you.
I think
Yeah.
our friend that does, he's family practice trained, and then he did a sports medicine fellowship, and he does a lot of these. He does Prolo, PRP. Yeah. I haven't had it, but I've heard of it. Yeah.
I've just been
Well,
tattooed. I figure that's like prolotherapy.
Well, I hope you never do experience Prolo, because what it is, in essence, it's dextrose. So it's basically sugared water,
Right.
which
It
we know
hurts.
to
It
be,
hurts.
yeah, it hurts a lot. We know it to be a huge irritant. And really what that was injecting sugar water, literally irritating that part of the body, so your body's own immune system activated. That's it. That was prolotherapy. So PRP did that, plus sent in the platelet-rich plasma factors to the area as well, and not nearly as painful. So far superior.
Yeah. So is there certain types of injuries that PRP works better for, or it doesn't work so well, or is it age groups or types of things? Is there a way to discern if someone's listening, like, oh, maybe it'll help my tennis elbow or my back or.
Yeah. So the original studies on PRP were really done on the Achilles tendon and elbows and knees with great results. But keep in mind, we're using your body's own platelets, right? So if you're 85 years old and you have a cigarette in one hand and a bottle of Jack Daniels in the other, right? Your platelets are probably not ideal. Even though that sounds like a good time, your platelets are probably not ideal.
At 85, I'm sorry to interrupt. I call the life goals.
Life goals. You're feeling no pain. You don't feel pain, so you don't need the.
Well, you're 85. It's like whatever.
It's
like, who cares, right?
So yes,
that's true.
Your immune system has to be functioning well to harvest platelets for. Yes.
Yeah, so I mean, your platelets are also 85 years old at that point, potentially, right? So the quality may be not as great as we would want it. The quantity is probably pretty low as well. So all those factors come into play. So ideally, you want to be within an appropriate age range, we'll call it, and with decent health. And obviously no sort of platelet disorders or platelet issues, because that will play into this as well. If you're on chronic aspirin therapy, that's also an issue, because aspirin irreversibly affects platelet function. So little things like that, which we would have to prep our patients for.
So basically it's the acute tendonitis is anything sort of under 3 months usually that it's going to help with. Obviously, you're not getting PRP on a bad hip, anything like that.
No, you'd be surprised. You could potentially do that as well. We've had success with degenerated discs, for example, where the jelly donut shock absorber in your back now looks like a flattened pancake. Injecting something like PRP into that, typically one procedure won't do it. You may need to do a series or whatever the case may be, but you can heal up a lot of those fissures or cracks within that disc. For example, let's say you have a labral tear in a hip, not just hip degeneration, but a labral tear, which is, and the labrum is basically, as you guys know, that kind of pillow between the hip and the ball and the socket. If there's a tear in that, you can direct the PRP towards that tear to accelerate the healing process in that as well. So it really depends on the underlying pathology, but PRP has a lot of uses. Even aesthetically, it's now being used for hair loss.
Oh, wow. I should try it. Maybe it'll get rid of my saggy eyes, but maybe that has to do with it.
Is it used in any cosmetic? Didn't I hear it was it they were using it for some cosmetic things too, facial?
Yeah, like the vampire facial.
Yeah. I thought I had heard of that. Interesting. Wow.
Yeah.
So is there a limit? Is there a point where you've done so many PRP treatments on someone and they're not getting better? You say done, like, do you do 1, 3? Is there a time?
Yeah. I mean, if you look at the pros and cons between cortisone and PRP, so the biggest pro for cortisone is its rapid onset. It kicks in very quickly, right? Maybe a week, maybe a little bit longer. The cons we've talked about, there's a ton of those, but with PRP, the pros are, we've talked about that actually, it's natural and all that stuff. But the biggest con is it can take about a month to kick in easily, if not potentially longer. So to answer your question, like, yeah, if you have a patient who's done 1 or 2 PRPs or a series of PRP, which is typically about 3, and they haven't necessarily seen any significant, not just pain relief, but improvement in functionality, range of motion, quality of life, etc., depending on what you're treating, there's really no indication to just keep doing it.
Are most insurances covering or not covering? Is this all cash or does it vary?
Yes, it's considered to be a non-covered procedure at this point, still across the board.
Yeah, that's what I thought. And that's why I think my buddy wanted to do the prolotherapy on me because of the cost of the PRP. And then he's like, it's cheaper, but it hurts a hell of a lot more.
Well, and I don't know, but I think that I'm a big fan of cash. And I think that we should be paying,
not doling it out unless,
No, but I mean, I think that, the patient engagement is different when somebody's paying for something. I mean, it alters the entire relationship. You're not dealing with insurance companies, which is spectacular.
Right.
And, you may not ever want it to be covered just because, if you have a successful business and it's a cash-based healthcare business, and in my opinion, that's the way. That is a far superior way to run a business. But
listen, I think your point is well taken, and I don't disagree with you, right? Because at the end of the day, unfortunately, the way that some insurance companies have gone in this country is the reimbursement structure is just unfair, for lack of a better word, right? So what that causes a lot of doctors to do is really increase the volume of their patients to, make the same amount of money, right? Which is not a good thing because then quality is massively sacrificed. But to your point, yeah, it is cash. And sure, there's benefits of that, obvious benefits of that. But the other kind of benefits of that is you now have a direct relationship with that patient. You have set up a situation with that patient where they are paying you directly for your services and you have to deliver those services. And I think that's far superior because you can spend the time with that patient, deliver that high quality experience, and truly change the quality of their lives.
It's exactly right. Like this has always been a mystery to me on how people do not understand this.
Well, it's like you would expect from any other service, someone building your house, the contractor,
cutting your hair.
Yeah,
exactly.
That's right.
But it's amazing to me. It's like, okay, so let me get this straight. The insurance companies are multi-billion-dollar a year multinational corporations. And if I take my money that I made and my employer takes money that I made for him and he gives it to the multinational multi-billion-dollar a year company, and then I get a service and they pay it back, that's going to be a better deal for me, having a multi-billion-dollar middleman. How does that work? It's completely insane. Of course, it's going to be less expensive and far better service if the producer and the consumer have a one-to-one relationship. And somehow people don't. I'm like, I would send prescriptions in for people. I'm bunny trailing. She's going to freak out. I would send prescriptions in for people and they go, it's not covered by my insurance. I said, yes, but the prescription is half the price of the copay that you would pay if it was covered. And then they look at me with like deer eyes and they go, it's not covered by my insurance.
Right.
And you just sit there and you go,
they don't want to pay for anything because their insurance is supposed to pay.
Yeah, it's just wild. It's like, and then you buy the insurance and then you want to use it.
But I'm like, but you bought that fancy phone you're carrying that's $1,000. And you bought
that's exactly right.
SUV you're driving and anyway.
Right.
We could go on
I think
forever.
we've all been kind of trained to believe that that is the way it should be, but it's really not the case. If you really stop and look at what you're paying for and where your dollars are going, because in addition to everything you just mentioned, now from the practitioner side as a solo private practice business, I now have to pay somebody to chase down the insurance company to pay me the money that I have earned.
It's so awful. The whole system.
We're primary care.
To stay away from that.
The happiest primary care doctors in the entire universe are direct primary care people. They can screen their patients. They have virtually no regulation. You have to obey the law, but we all do.
Right.
And they just get their subscriptions paid. They get the patients love it because their service is way better. They have
Right.
tons of access. It solves all of these problems, but but you got to pay $75 a month.
Right.
And I'm like,
I know, but
It's crazy, right?
I'll pay for my Peloton membership, but not to go to the doctor. It's funny
Well,
the
It's
psychology behind
crazy.
it. Right.
It's true, right? And we have an elite membership program in my practice where they have my cell phone. So they can call me at any point or text me, and I'm happy to comply and help those patients out as much as possible because they understand the value of the service.
Right.
So they get the value of the service.
Exactly. Just like, if you have your attorney on the line,
well,
it's the same
Right.
Until we got into a couple contract disputes in the last 4 years, we never really thought much of lawyers. Now I love them.
Yeah.
Like
That's funny.
It's amazing. It's just like,
So why don't we tell us a little bit more about these stem cells? So we were doing PRP training that. Did you learn how to do stem cell injections at the same time, or is that kind of different? What's your
Yeah,
thoughts
so
on stem cells?
Yeah, so PRP is great, right? But there's always that patient population that either wants the latest and greatest, really the best thing out there that's available, or PRP just isn't enough,
Right.
like everything else in medicine, right? And so PRP basically is a purified component of your blood with the associated growth factors, but stem cells is the source, right? And so autologous stem cells, meaning coming from your own body, the bone marrow basically packed with everything that PRP has plus more. So millions upon millions of growth factors, not just different growth factors, but also greater quantities of growth factors, as well as fibroblasts and just the whole 9 yards. So the other kind of practical benefit of a stem cell procedure is volume-wise, you can typically get much more. So let's say you're treating a larger joint or a larger open or unencapsulated joint, like a hip, for example. With PRP, you can typically get about 3 to 5 milliliters of PRP per blood draw. With stem cell, you can get 10 to 12. So you can really blanket the entire area.
Now, tell everybody that doesn't know how stem cells are acquired. What kind of process? Just quickly, you have to go through to get your stem cells, and
Black and Decker.
what that feels like, and what that costs.
Kind of.
Yeah.
Yeah, stem cells are acquired. Most of the time, most commonly, I'd say from the hip,
Mhm.
what we call the posterior iliac crest, which is basically kind of where your hip lies in the back. So
Yeah.
just below your belt line, basically. And the way that I actually extract those is under the live X-ray, under a live fluoro. A lot of people will do it blind, where they just tap, tap, tap. But if I can see where I'm going, I can direct specifically towards the kind of thickest, most dense part of the cortex or the bone. And truly, it's literally just kind of a large needle, a large straw, metal straw, basically, that we tap into the cortex, past that bone into the actual bone marrow, and then we aspirate the fresh bone marrow right out.
How and is that pretty? So I remember us learning how to do bone marrow aspirations, and it was grueling. It was awful. So has it changed? Has it evolved over the last 30 years, where it's pretty much more humane and not too painful to do that?
You would be surprised at how comfortable patients can be doing that, right? But as an anesthesiologist, originally, I'll place certain nerve blocks in first.
Of course.
So I really anesthetize that area really well.
Yes.
And I can literally have a conversation with my patients as I'm extracting the bone marrow.
Yes.
It's incredible.
Yeah, you can imagine how we were trained that long ago, what it was like. It was like Dexter, basically.
I remember 30 years ago, it's like, okay, we're going to go in there. This guy needs a bone marrow biopsy. And it was just like, like damn near standing on the patient, and it's just like
post-hole digging.
Patient is super uncomfortable, and they're yelling, and it's like, hold still. I mean, it was just
orderly sitting on them. Yeah, it was.
Well, plus it's in Canada, right? Now they're like, oh, you got cancer, we'll just kill you. So
call the maid.
That's funny. But the beauty also of stem cells, I'm sorry to interrupt you.
Oh no, go ahead.
Similar to PRP, is everything is done in one sitting, right? So once the bone marrow is extracted, and the patient is literally re-injected at that same visit with the stem cells. So there's no preservatives, there's minimal chance of contamination. You're not kind of putting anything in the freezer for the patient to come back or what have you. It's all done in one sitting.
Nice. And this is this commonly done by physicians in pain management clinics now? I mean, I know a lot of ortho or sports medicine will do it. Is there a big overlap? If someone's like, oh, I've got this chronic, or I have tendonitis all the time, like I do from what I've got going on. But if they wanted to seek out somebody that did these things, PRP, Prolo, or stem cells, does it just depend on where the area you're in, and is it done often by pain management as well as sports medicine where you are?
Yeah, it's a pretty
Yeah,
accepted kind of
yeah,
modality these days, right? So,
yeah.
in my area, at least orthopedic surgeons do it, sports medicine docs do it, interventional pain docs do it, even some functional medicine and anti-aging docs do it.
Right. Okay.
So it just depends on the area and the doctor, I think.
Gotcha. So let's go.
Let's
Take a
go anti-aging.
take a journey on. Yeah. So how did you get into the functional anti-aging world? Is it just kind of a natural extension of what you're doing, or something else pop up, or what?
It's always something I've always had a parallel interest in for years and years, to be
Oh,
honest. And I've always kind of trained myself on it in spare time or what have you. But during the pandemic, one of the beautiful things that came out of that is I had a lot of spare time. So I took that as an opportunity to really kind of complete my training in anti-aging and regenerative medicine and get board certified in that. So it's always been kind of a parallel path, but it also relates back to the patients that we're talking about, which is basically all of us and the system as a whole, right? Because you can treat a nerve, let's say, because a disc is degenerated and causing sciatica. But if you take a step back and ask yourself, well, why is that disc degenerated in a 45-year-old male, for example, right? What's going on here? And maybe there's other issues at play. Maybe that patient's testosterone is super low and their bone health is really poor because of that, leading to these issues. So I can do epidurals all day long, but if we're not treating the underlying problem, we're just kind of chasing our tail. So I saw that a lot with my patients. I saw a lot of these kind of hidden links between the two disciplines. So I started pursuing anti-aging and regenerative medicine for that reason.
That's
and
really fascinating, because we have he's also from Southern California, Robert Yoho, who was a cosmetic surgeon and a really interesting guy. And we've had him on the show 3 times or so. And
Nice.
but he did the same thing. So he's doing all these cosmetic procedures, right? He's doing tons of liposuction. And
Yeah.
then he just starts reading kind of out of his area. And he's like, what I'm basically doing is I'm treating largely women for hormone deficiencies. And
Totally.
so he just read up on how to, treat people, how to treat men and women with hormone replacement therapy. And then he just started doing that. And they're like, oh, you can't believe, like, so he would do a tummy tuck and put testosterone pellets under the skin because they were already anesthetized. And these women come back and they're like in tears because finally, like they feel like normal.
Or you get it. They begin there and there's like, I need a facelift. I want this and that. And he's like, hon, if you just were on hormones, you took care of your skin better, then you wouldn't need all this. So it's the same thing. And it's fascinating how I think a lot of physicians, even in our situation where we're at doing family practice, urgent care, but a lot of us are starting to take a step back, and instead of just being the physician treating disease, now we want to treat and prevent more. When we went to school, it was preventative medicine, we called it, but it was kind of goofy. It was more screening. Right. It was all about screening for cancer, screening for whatever.
Yeah, but most
lifestyle, diet.
But most of it's garbage, because most preventative medicine is going to the gym and eating properly. That's preventative medicine.
That's right.
And May nailed it. Like, we went down the hormone replacement rabbit hole, and our listeners love that, right? Because it's just like, holy cow, there's potentially hope. But you sit there and you go, we would screen patients every single year with a TSH to see if they were deficient in thyroid hormone, right? If their T3, T4 is too low. And then you sit there and you go, okay, so human beings, how long are you supposed to live? The answer is nobody knows. But realistically, from an evolutionary perspective, once you're past sexual maturity and you've pumped out a couple kids, you're allowed to die. So how long is normal levels of estrogen, testosterone, progesterone? How long is it supposed to exist in a human? The answer is we don't know.
And if you go to test for them
if you go to test for this,
a Western medicine doctor
to make them feel better, if it was thyroid, that's okay. but somehow, oh no, it's just the natural part of aging to feel like dog crap and have a testosterone of 150. And I'm like,
No,
are you
you're absolutely right.
kidding me? Like,
You're absolutely
how does
right.
that make any sense at all?
Well, that's the crazy thing, right? Is like after the age of 30 in males, our testosterone goes down by 1 to 2% every single year. But that's, there's a huge thing here that nobody in the testosterone hormone replacement world has talked about. Testosterone is not just for libido and like being buff at the gym. There's so much more involved in that. Like truly bone health, we can increase bone density by 8% a year with testosterone replacement. That means, guys, you could literally reverse osteopenia or osteoporosis. You could reverse it and you get all these secondary benefits of testosterone. I think another huge problem is the labs, right? Because a normal level of testosterone, depending on the lab you go to, could literally be like 200 to 1100. It's like, are you kidding me? I could fall anywhere in that and I could be normal.
Yeah,
so if
and
I'm
plus
250,
it's probably from unhealthy people who are high or testosterone deficient anyway.
Well,
that lab range, right?
I am floored.
Totally.
I am floored at how many, if you actually look for it, how many 30 to 45-year-olds have levels that are like 200-ish, or like, it's just holy moly.
Oh yeah.
And like, where is this coming from? Like, it's I sit there and I go, if you knew what my level was, you'd freak out. But I mean,
yeah.
it's just, it's amazing. And this, I had a patient ask me, he just said, I have friends that are on, TRT, and I want you to check it. And this guy wasn't very old. And I was like, oh my gosh, I'm amazed, we're going to make you feel so much better. It's just not even funny.
That's right. That's right. And you know where it comes from, right? Is in our society now, more processed foods, more sugars, more inflammation, more stress, right? This kind of grind and hustle culture that we've created, where any sort of rest or sleep or self-care is really poo-pooed upon in many situations. That's where it's coming from. So kind of males are grinding themselves down to a point where their testosterone is suffering dramatically. Stress management is out the window. I mean, nobody even does that properly, right? And then you go to a primary care guy, and if you don't know any better, they'll typically call you and say, they'll read your lab results. Say, oh, you're 250. Hey, Mr. Smith, your testosterone is normal. Thanks. I'll see you next year. Bye. Click. That's not normal, right? That's what we take that. That's exactly what we do now is we optimize that. So we don't want to be normal. We want to optimize, right? So I'm in my mid 40s, and my optimized levels should be 900 to 1100. But at baseline, I'm probably cruising around 400 or so. It's not normal. But that's a turn that we have to educate our society on.
Well, yeah, and then the other thing that used to drive me absolutely crazy is they go to the primary care doctor and they're 75. They finally get a level. Their level is 75. They're 75 years old with a testosterone of 75, and they're like, okay, you need treatment.
Oh, they give them a shot.
So they give them a massive whack once a month, and they assume that the depot testosterone just magically stays in there for 30 days. So then they spin off all this estrogen because now they have a level of 2,500 or 3,000 for 3 days, and they come back and you see them 6 weeks later. No real change. You see them 2 months, 6 months later, and it's like, it didn't do anything, and now I need a bra.
Totally, right?
And
that's
like,
the other.
What?
Yeah. No, you're right. And that's the other kind of issue is mismanagement of testosterone replacement, right? Because it's one thing to say, okay, let's say you do have somebody forward thinking who says, okay, your testosterone is low. I'm going to give you this non-bioidentical injection that maybe you can do at home, right? Testosterone cypionate, for example. Now you're injecting every week, right? Which A is a total pain in the ass, literally and figuratively, right? But B, you're spiking your testosterone and dropping. But C, if you're not blocking the aromatization or the conversion of that testosterone to estrogen, to your point, you're going to become more feminized. You're going to get man boobs, you're going to get emotional lability, the whole 9 yards, and you're going to think testosterone doesn't work for you. It's being mismanaged.
But you binge home and garden network. So there are
How much?
benefits. That's right.
Oh my God. Maybe I can get him to watch HGTV with me that way.
No, I'm watching the Jewish Nazi hunters. I'm sorry, I'm addicted to that. So
how much of your practice focuses on? So we've done a few shows on hormone replacement therapy with Robert. He's written a whole book on it, and then we've had some other functional medicine practitioners. How much of your practice focuses on that? Because I know you do so many other things too, which I kind of want to pick your brain on, the peptide therapy, etc. Is that a big part of it? I think rightfully it might be, because we downplayed, well, in our in our medical school training, hormones and hormone replacement was always downplayed, but it's such a big part of aging.
Well, yeah, because it's going to give you raging cancer of one kind, right? I mean,
So is that a big part of your practice, is you doing hormone therapy?
I think it almost involuntarily, it's an increasing side of the practice. It's something that people actually want, and they come to me for more and more, right? Because they understand how their quality of life can be vastly superior. So it is a large part, and it's increasing. But what I do is I really like to quarterback the entire patient care experience. So we have kind of programs that we offer, and in those programs, they're all inclusive, which I think is really the best way to do it. And that includes like labs, certain supplements that these patients may need as well, managing the hormone replacement, like the TRT or whatever the case may be, as well as potential peptides and things of that nature. But there's also the mindset component, which I really focus on. I don't want patients to minimize, right? If they don't have the right mindset on their overall health and why they're doing what they're doing, nothing is going to work. I mean, I can give them everything, but if they still are going to eat Lucky Charms every night, like I accidentally did last night, nothing is going to work. Nothing is going to work.
Yeah, but they're
the first step is the mindset.
They're magically delicious, though. So you can't beat that, right? No, but that's exactly right. The mindset part. I mean, it was so funny, right? Like I I've run 12 marathons. The last one I ran, I don't know, I was 35, 36 years old, something like that. And and then you start and then tons of skydiving and lots of skiing and God knows how many hours windsurfing in the gorge, and my knees started to get started to fray my menisci, et cetera. And so you have to change activities. And then I had a really pretty significant, I broke my left lateral meniscus basically in half. So then I just got lazy, and I gained about 25 pounds, and I could still ski and so forth, but I was just kind of it wasn't good. And I knew everything to do because I had done it before, but it never worked till I got a trainer, and then it worked unbelievably well. And it's just like, it's so crazy. Like all the knowledge I had, all the training knowledge I had, it didn't really work until I had
someone else to bitch at you other than me to do it.
Correct. So, but it's amazing. But they're also bringing insights and seeing things that you're not seeing, even if you're an expert in that thing, because you're not an I mean, I'm great at my job, but I'm not a coach. I mean, I'm
right.
And so much of what's going on in primary care now with all of the metrics and stuff we're doing, they're trying to make me a life coach. Well, I'm not trained as a life coach. I'm trained as a doctor.
Right.
Yeah.
Yeah, it's true. It's true. You know what I tell a lot of my clients, right, in the anti-aging kind of concierge programs that I've developed, I'll get the call, just like I do this too. We all do it. Like I'll say, hey, Mr. Smith, did you start X? I didn't start it yet. Or did you get your labs done so I can take a look? Not yet. I was busy with excuse 1, 2, or 3. I literally will kind of remind them, kind of going back to Stoic philosophy, like an urgency to this, right? You only have maybe, if you're in your mid 40s, you only have maybe 40 more summers left in your life. You only have maybe 40 more winters left. So the more you delay things, the more you're just kicking the can down the road and literally ignoring the life that you could have. And when I have these types of conversations with people, it really gets them moving to get the job done.
I love it. That's really, I mean, for me, that works. I think of my 50s, which have been an orthopedic mess. And I look back at, because And I'm like, ugh, I'm almost done. My whole decade has been dealing with this stuff, just for better or for worse, of the way God made me. But
Yeah,
you're right. You
yeah,
have to put it in that perspective, because there's always tomorrow. Otherwise, it'll always tomorrow. But as we get older, time seems to go faster. And you're right.
it's true.
No,
It's true.
time is exactly like skydiving. When you get out of the plane, you have no real reference to the ground, but you are actually rushing to the ground at the same speed the entire time. But when you're at 1,500 feet, it's way more intimate than when you're at
Really
15,000.
good analogy.
You know,
love
it's
that.
like,
I love that. Yeah,
it's
that's
just like,
great.
So what other modalities are you using then in your anti-aging clinic?
Yeah. So supplement therapy, right?
Mm-hmm.
So there's certain supplements that can actually, like, for example, naturally mitigate or minimize the aromatization of testosterone to estrogen, right? So things like that. There's peptides. So peptides are basically small amino acid chains. They're like small proteins that exist in our body already. And these small protein chains are basically signaling molecules. So they tell our body when they're floating around to do certain things, and they kind of modulate hormones. They can modulate the amount of glucose in your body, the amount of insulin in your body, the amount of a growth factor in your body, right? So taking certain peptides can change the way your body responds when dealing with those types of hormones. For example, there's one that's called BPC 157, which helps your body heal quicker, right? So if I'm dealing with an athlete with, let's say, a busted knee, and we do PRP or stem cell on that knee, then give them BPC 157, they're going to accelerate the healing process. But if I'm doing that, I can also monitor their testosterone at the same time to improve their bone health if that's an issue, and do all of this collectively under one roof.
So use them
Um,
together. It's not, oh, I'm here
yeah,
to get peptide therapy, or I'm here to get it's all used together in conjunction. That's what you're saying.
ideally,
Yeah, I mean,
ideally.
I've been hearing more about peptide therapy. I don't know a whole lot
well,
about it. I knew it in the anti-aging world, and from I'm really caught up lately on a bunch of books. Mercola to James DeNick. He's one of my favorites, and
Hmm.
even just
Nice.
learning about autophagy and all that type of thing. But
That's right.
what the peptide therapy, I hear of it, patients or friends asking about using it for weight loss, infusions, and things like that. Do you have any comment on or knowledge on that?
Yeah,
That?
yeah. I mean, like, the semaglutide, we've all heard about that going
Yeah.
crazy right now, right? So that's one that's, this miracle weight loss drug. But what nobody talks about is the anxiety, the nightmares, the depression, the central nervous system effects associated with it. There are other actual peptides that do help with things like weight loss. But I think, like anything in medicine, like anything we do, everything in moderation, right? Anything that we've talked about today, if you take it in excess, you're going to run into problems.
yeah,
Yeah.
the thing that always makes me nervous is just, is there downstream effects, 10, 15 years from now that we don't know about? It's like, I'll be 58 in a couple months. So, my downstream effects aren't as great because, I'm not a kid, right? So if I have a CT scan, who cares? I might live another 30 years. I might not. You start irradiating people that are 6 months old, you got a real problem on your hands,
That's right. That's
And
right.
so I always wonder about some of this newer stuff, like hormones we've known about for a long time. And so that always makes me nervous, especially when big pharma gets on the bandwagon. Like, I mean, Ozempic is absolutely crazy how many patients want that.
I know.
And I tell them the study. I say, look, 40% of people lost 10, was it 10% or 5% of their body mass?
I think it's about
So
8.
if you're 220 pounds, you lost 10 pounds.
And it's yeah.
Right.
Yippee-ki-yay. And then I see another
if you go
patient
off of it,
and they
what's gonna
lost
happen?
70 pounds. Like,
Right.
but it's because he just stopped eating. It just made him like super not hungry, which I don't understand. But
Yeah. But then they end up gaining all that weight back, which I think you just said. They end up gaining it all back anyway, right? So what are we doing here? Now,
Exactly.
again, that just goes back to mindset for me. Like, yeah, you can take the easy way out by taking the new fad drug, whatever that may be, or you can change your mindset, understand what you need to do, build structures, build a routine for yourself. How do you start your day? Do you just wake up, randomly start eating, whatever is on the table, or do you have a system in place? What are you doing? What's your nighttime routine? How often are you exercising? Why? Are you doing aerobic, anaerobic? What are you doing? And if you don't know what you're doing, you start there. Don't look for the miracle drug.
No,
I think it all starts with mindset.
No, I think you're 100% correct. The thing that's so fascinating, and I don't know how many people we've talked to about this on the podcast, is that, people think that they need to be motivated, and people think that
Right.
they need this intense amount of discipline. No, what you need is ritual. Ritual is what saves
Exactly.
people. Like
Amen.
if you're waiting for motivation, then just stay fat and be happy and enjoy the Lucky Charms and the insulin injections that undoubtedly will be coming your way, because and that's what just drives me crazy, because motivation, I mean, it's the David Goggins kind of stuff. Like, if you only do stuff because you're motivated to do it, no one would ever go to work or brush their teeth. So if you can go to your crappy job working as a garbage man and brush your teeth and take a shower every day, then you can add other rituals like eating a different kind of diet, exercising a certain amount of time, going to bed at a certain amount of time. Like, all of these things can become rituals, just like all the stuff you already do. And that's the key, because the motivation part always, well, I'm not really motivated to exercise. Well, I never was when I started. And then eventually I couldn't live without it.
Right. It's like, I'm not motivated to brush my teeth every morning, but I do it. Right. And eventually it becomes a habit, just like that.
Yeah,
exactly. Do you have any other little favorite, I don't know, tricks or things you like to use in your practice as far as functional or anti-aging things that we haven't kind of hit on?
Yeah, I think, ultimately what I talk to a lot of my clients about is just keep it simple, right? Just keep it simple. If you get 20 minutes of sunlight a day, every single day, you drink electrolyte-based water, maybe, 3 to 4 liters a day, you work out 3 to 4 times a week, you eat clean, right there, you've solved 90% of your problems. Just keep it simple and keep it consistent. That's it.
So that's really,
it.
I have tried to trade the 3 liters of water for 3 liters of vodka. Unfortunately, it is less effective.
You could probably do that once.
And it pisses her off, so I don't do that. So, but like I said, sarcasm is my love language. Yeah, no, that is really great. I love that. Like, the thing it freaks people out. Like, I have these patients, and I'm like, salt is not your enemy. It's not the problem. Sugar is your enemy. If you get off the sugar, you can eat. Like, salt is not a problem. Well, what do you mean? I have high blood pressure. I said, okay. Let's think about this. Okay. You can go for 40 days like Jesus without eating, and you're not going to die. But you can't go. You have to have the right amount of salt or you're dead.
Mm-hmm.
You can.
That's right.
I mean, I remember when Tim Noakes, who's a famous physiologist, he's an MD, but he was talking about doing the electrolytes at people after the Hawaiian Ironman, and how they always had 2 or 3 patients that were hyponatremic because they drank so much free water that they almost killed themselves with hyponatremia, and they were exercising for 16 hours. Wow. So it's not hard he said you could run 2 marathons back to back in 80 degrees. You would feel like garbage if all you had was a salt lick. That's all you need. And I was like, wow, okay, I got this wrong. This is really interesting.
I think that's another thing. It's a great topic, because I've done
we need to do a show just on salt.
Well, I've read the Salt Fix, and how, as a medical profession, and it was pushed by the probably drug companies that got into the heart, the cardiologists and heart disease, about how sodium bad, when really it's the balance of the electrolytes that's important. You need sodium and potassium to be balanced, plus magnesium. I mean, all these factors but we've done such a disservice to our patients by just poo-pooing sodium that it would cause
it's so crazy. It's like, okay, so the sickest people with 6 months to live that have congestive heart failure have to be careful on how much salt they eat. Therefore, no one should eat salt.
Yeah, it's crazy. It's crazy.
That's where it came from.
Yeah, makes no sense.
So if someone wants to look you up because they're now totally intrigued by your approach and all the services you have to offer, why don't you let everybody know where you're located, but how they could look you up if they're in your area, or I don't know, do you do online consults?
Yeah. I mean, I treat clients nationally, so we definitely have that ability. The company's called Remedy Wellness and Anti-Aging. So our website is thinkrws.com. Think Remedy
Yep.
Wellness Solutions. So thinkrws.com. I'm also on social media on Instagram. It's just my name, MD. So Akash Bajaj, MD.
Perfect. I'll put those in the show notes.
See,
And
it's Bajaj. It's not hard to say. We just get scared.
No, I get.
It's not so bad. It's not so bad.
Exactly. It's phonetically exactly like it looks. It's very easy.
So living in California, does anyone pronounce it Baja?
Yeah.
Oh, yeah. We get that a lot. The Hispanic influence is strong. So it's all good. It's all good.
Interesting.
Yeah.
It's all good.
Yeah, absolutely.
This has been super fun. I mean, I love how you've taken us right from the beginning of, the pain management and the evolution through the PRP world and then just looking at prevention of getting to the chronic pain phase as best as we can, try to make use of our skills and our tools to live our best lives and not get to the decrepit phase.
Well, but that's the point. I mean, that's just absolutely driven me also. I mean, obviously there's a lot of stuff that drives me crazy, but it's like this idea that we can extend people's lives, but not extend their quality of life. And so,
correct.
I've had this conversation with tons of patients. I said, look, okay, we're going to do a really good job to make sure that you're super miserable for the last 5 to 10 years of your life, because you're not going to die. You're going to treat your heart attack at 55 perfectly. We're going to get you to quit smoking. You're going to whatever. And now you're going to make it to 82 or 83. And you wish you would have made it to 73. And so, and then I see young people and I'm like, okay, you got to get on this right now because now is the time to not be 300 pounds because you will have a terrible existence going forward. And I mean, it almost, I mean, it makes me sad because
it's true.
I mean, I know how easy it was to maintain my weight, even in my mid 30s compared to, it's like, it doesn't get easier.
That's right. Absolutely true. And again, going back to the basics, diet and exercise at that point will do wonders, right?
Yeah. Like, oh man. Yeah. It's, wow. Again, like everyone we talk to, we've made such good friends doing this. We could go.
That's awesome.
Down the bunny trail for hours.
No, you guys are great. I really had fun. This was really nice. Thank you so much.
And I really enjoyed sitting in the sunlight with you because here in Oregon, it's like a rare, it's like Halley's Comet sighting or an eclipse to see the sun in the winter.
When you said get 20 minutes of sunlight a day, and I was like, well, you don't live in Oregon in the winter.
That's why I have a happy light. Anyway.
Yeah, there you go. Whatever gets it done, right?
That's right. I have all these tools in my toolkit too. So thanks for joining us on the show, and we will put those links in the show notes. And thanks again.
Thank you, guys. It was a real pleasure. Thank you.
All right.
Well, that was really great. He has an unbelievably great ability to explain things in a way that I think most people can understand very well.
Just how friends who listen to the show that always said, "Slow down. We didn't get that because you medical people talk too fast and don't explain." He's a great teacher.
Really great teacher, and I mean, I just love how we talk to all these different people we've never met, and how the themes always seem to be the same. It's mindset, it's ritual, it's, you can have all the hormone replacement in the world, and if you're not willing to do the stuff, the big stuff, it's not really going to make that much difference. You got to be willing to, put in the exercise, look at what you're eating, change it, all of the common sense.
Right.
And that's what he said. I mean, I love that.
Keep it simple.
Drink some salt, drink a bunch of water,
eat healthy,
and work out at least 3 days.
To be healthy and get some good quality sleep. I mean, it's things that most of you guys know already, right? It's the common sense stuff. That's a place to start. And know that doesn't matter who you are. I think he even said he ate his Lucky Charms the night before. Everybody has their pitfalls, and it's not always easy. So don't look for some big inspirational motivation on like January 2nd. Just the little baby steps every single day. That's what I do.
Yeah,
even 10 minutes.
It's ritual.
Yeah.
I mean, it really is. There's
definitely ways for you to seek out improving your health. Look into PRP or stem cells in your area if you think that might be helpful for your issues. But look at trying to prevent yourself from getting to that point by doing the right things now and avoiding having to get there.
And, you know, if I was really super duper interested in a lot of those therapies, I would just travel to somebody that I trusted.
Absolutely.
Because we didn't get into it. I actually thought of it and I forgot to ask him, is especially with the PRP stuff, how important is the skill of the operator? And I think that that's still a thing, you know, being able to put it exactly in the right spot in your hip joint,
I don't know.
et cetera, et cetera.
I'll have to look that up because we do shoulder injections and we didn't have any massive, it was more like a see one, do one, teach one. So
yeah, but shoulders and knees are gigantic joints,
as far as PRP,
and they're not that hard to
I don't know.
inject.
Maybe it's like tattoos. It really varies on the operator. You're right. The quality of
because as we know, tattoos and sushi, good sushi will change your world, just like a great tattoo. Bad sushi, on the other hand, is just plain bad.
Yeah.
Just like bad tattoos.
Pretty much bad all the time, in my opinion. Well, we hope you're having a good month of March. Happy St. Patrick's Day if you celebrated that. And maybe spring break's coming your way and maybe some better weather. But it's gross here in Oregon, and we've had a very filled month. If you've been following our social media, we haven't posted much, if not anything, about our moving because it's been too overwhelming. My hip is coming along great. My hip replacement is, this show's going to air, I don't know, so I won't tell you how many weeks, but I'm doing well. I'm on to my next project, so stay tuned on Instagram about what I'm up to with my body next because there's another orthopedic project coming up ahead, and we will be living elsewhere soon.
Yeah, and you know, if you take 29 years of accumulating crap and have a 30 by 33 foot garage
and a yard filled with plants
and 8 acres, and you have to condense it to a 1,200 square foot house and a tiny 1.5 car garage, it's unpleasant.
Especially when you sold your house on week 3 of hip replacement.
Well, right, because we knew the hip replacement was going to be like a buyer magnet, that as soon as the hip replacement was done, a buyer would come. And not only did the buyer come, the buyer came and said, we want to close in warp speed.
You all know how that is. It always happens that way. And I said, as soon as
we were very happy. They have been unbelievably accommodating.
It's been an awesome
I cannot imagine dealing with people that would be.
I agree.
I mean, it's just been, it really has been the actual great. Selling to the buyers has been spectacular. That has not been an issue at all.
All of our stuff, our shit, like I like to say.
Well, the issue is
think we had much shit. I didn't think we had that much shit, but holy cow, when you start to pack that shit, that's a lot of. And
then you find things that you haven't known you owned that you never even used or took out of the container.
And then someone wants to keep them.
It's just amazing.
Needless to say,
it's
we're
amazing.
having a big garage sale in our house. I'm amazed. We have a whole room full of more stuff to sell, but it is amazing how much stuff I'm finding stuff. You're finding stuff. And I'm like, do we need all this stuff? It's a really good process. So if you think you've cleansed your house or your home and Marie Kondoed it all, do it again, because you probably would be surprised at how much stuff that you don't really need, that you don't really use. That's, going to get passed on to the
for instance, every single National Geographic from 1960 to 2005.
Yeah, but those are collectibles.
Right. And we were just going to give them away.
Encyclopedias.
We were going to give them away until we realized that there's like $2,000 worth of National Geographics.
I know.
And then people are like, I'll give you $100 if you ship it for free. Right, because it will be $1,000 to ship that.
Crazy. Yeah. There's been some treasures we found, like that T-shirt that our son had, that concert T-shirt. I didn't realize, I haven't sold it yet, but I didn't realize a used concert T-shirt would be, worth so much money.
Well, it depends on the concert.
Exactly.
Right.
It's been fascinating.
If it's the Irish Rovers,
but things
probably
you think
not
are
worth very
valuable
much.
to you, people look, it's like 10 cents. I'm like, yeah, I'd rather throw in the garbage for 10 cents than 10 cents. Then give it to you. That's my attitude. So anyway, big estate sale coming your way. It'll be over by the time you listen to this. But this whole process of moving has been a grunt. And I don't know if I do it next time, I'll have a lot less stuff. So,
oh, well, next time, it will already be in boxes. And then we will put those boxes into a U-Haul. And then we will put more boxes into a trailer behind the U-Haul. And then we'll drive 3,000 miles. So that will be awesome.
So we're downsizing by half, and then we're going to downsize by half for sure again. And then we probably won't ever care if we have that stuff again. Living in a van down by the river.
Yeah, there's some.
You want your stuff.
There's some stuff I want to keep.
Tim likes stuff.
I like cars and motorcycles.
It reminds me of VeggieTales and Stuff Mart with Madame Blueberry.
Yeah,
Is that Madame Blueberry and Stuff Mart?
I don't.
If you've never watched VeggieTales and Stuff Mart, you need to watch it.
I think cars, motorcycles, and a decent stereo is very important.
That stuff takes up a lot of room. Is the thing.
Yeah.
A lot of room. Like you and Jay Leno need to acquire some realty together.
Yeah, because I have 2 cars, and Jay Leno has like
some people like
250
I know,
cars.
Not even close, right? But if you had the income that Jay Leno had, would you have that many cars?
I don't know if I'd have that many cars, but I would have more cars.
And I would have. Say,
I forgot.
How many motorcycles?
I forgot pinball machines. Yes, I'd have more pinball machines too.
Forgot about moving those stupid things too. Not stupid, but those big things too. Yes.
Pinball machines are really heavy, but they're actually easy to move. You take the glass out and you remove the balls and you put the balls in a bag. So now you have a bag of balls.
A little ball sack?
Yes.
It's a pinball ball sack.
It's a pinball
ball
sack. And it's a ball sack you could literally beat somebody to death with because it's filled with pinballs.
Be that heavy. It's like brass knuckles.
And then the legs come off and they the back glass folds down, and all you need is a hand truck and you're good to go.
It's folded faster than an old man that's had his balls cut off.
Correct. But you have to take the balls out, or else they beat when you go to move it, it beats the crap out of the pinball machine because the balls are flying around indiscriminately. Yeah, and no one wants balls flying around indiscriminately. That's bad.
Just a bad thought right there. Just sounds really bad all the way around. All right, well, we better get to it. You haven't cleaned that up, so Tim's got to go take his balls out and put them away in a safe place for the rest of the move. We will be back next week with another fun episode. See you next time.
Have you heard of hyperbaric therapy?
If you want better circulation, oxygenation, or respiration,
turn up the volume.
Everyone appreciates the increased energy and clarity.
Athletes say goodbye to those PRs because you're going to blast
So
them.
how's it work?
We load your body with oxygen.
That means
less inflammation,
fewer allergies,
faster healing, and more.
Come see us, 1200 Executive Parkway.
You know, the Upside Down building.
Call us, 541-636-3278.
That's 541-636-3278.
We have some incredible deals.
Heal, build, and thrive
with New Leaf Hyperbarics.
Got air?
It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
While we try to keep BS Free MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.